This is Lecture 9, Behavioral and Cognitive Approaches to Psychotherapy, and your reading this week is Chapter 14. So some reminders and announcements. Homework 9 will be due this Sunday at 11 p.m. And then Exam 2 is going to post the Monday after, so this upcoming Monday, and it'll be due on the following Sunday, 11 p.m. as usual. And this will be a lot like Exam 1, maybe more free answer questions than Exam 1, because I think we're covering some content that's I'm more interested in you thinking about the content than memorizing terms, etc. There will be a deviation from the syllabus this week, which I had mentioned in an announcement last week. So we're going to be covering Chapter 14, Behavioral and Cognitive Therapies, and then we're going to just briefly cover third wave therapeutic modalities at the end of this section. I had originally planned, and on the syllabus I had originally planned to have 2 weeks, but we're just going to collapse it into 1 week. The third wave modalities are going to be covered rather briefly in the lecture, and no additional readings are required. However, third wave modalities are super interesting, and a lot of people, including me, are really interested in using them in therapy. And so if you are more interested in third wave modalities or would like some materials, I'm more than happy to provide this. So we're going to talk about cognitive approaches and behavioral approaches, and then CBT, cognitive behavioral therapy, and then again the third wave modality. So starting with the behavioral approach, some of this wasn't covered in your book necessarily, but I think it's important to sort of cover the background of the behavioral approach. There was a heavy scientific emphasis in the behavior approach. It was kind of a reaction to psychodynamic and more philosophical theories that weren't necessarily able to be studied scientifically, or at least the theories couldn't be studied scientifically. So behavioral approaches de-emphasized any kind of inferred variables that can't be directly tested, or at least self-reported from the patient. And a lot of the behavioral approaches were based on classical and operant conditioning. So you will likely remember this from your psychology, introduction to psychology courses. So classical conditioning is closely associated with Pavlov, and he conducted these studies with dogs back in the early 1900s, noticing that dogs would salivate at the sight of the technician. Pavlov predicted that a stimulus could be paired with food, and then that stimulus by itself could later lead to salivation. So Pavlov came up with this structured way to talk about conditioning and to sort of operationalize conditioning. So there's the unconditioned stimulus, unconditioned response, and then the conditioned stimulus and response. So before there was any conditioning, before these conditioning was performed, the unconditioned stimulus was food, and dogs would salivate, so that was the unconditioned response at the sight of food or the smell of food. And there was a neutral stimulus as well, which was a bell. Before conditioning, the bell had no meaning to a dog, and the dog had no response. And then during conditioning, the bell would be associated with the food. So dog sees food and salivates, and sees and hears, sees the food or smells the food and hears the bell at the same time. So that those two stimuli become associated, so that the bell becomes the conditioned stimulus, and the conditioned response becomes salivating. So even in the absence of food after conditioning, the sound of a bell causes the conditioned response of salivating. In the 1920s, Watson and Rayner generalized classical conditioning studies to humans. So famously, they studied this boy named Little Albert, and Little Albert, I think he was quite young, like a baby, not quite walking, and he was not afraid of animals. So he wasn't afraid of rats, he wasn't afraid of bunnies, he wasn't afraid of dogs. But loud noises would make him cry, as it would with most babies. So they paired a loud noise with a white rat. So they gave him a white rat, and every time he saw the white rat, they would scare him with a loud noise. And this resulted in Little Albert learning to fear rats and learning, so first he learned to fear rats, and they also observed that this generalized to other animals. So only the rat had been associated with the loud noise, but little Albert was now afraid of bunnies, which he hadn't been afraid of before. And this was taken as evidence that phobias, so little Albert now had a phobia of white rats, so this was taken as evidence that phobias can be learned by humans. If you like to see children being tortured, there's footage of little Albert in these original experiments. And then Mary Cover-Jones, a couple years later, kind of had a more humane take on classical conditioning in humans, and she studied this 3-year-old boy named Peter who had a pre-existing fear of rabbits. And Mary Cover-Jones wanted to know if Peter could get over his fear of rabbits by associating rabbits with something positive. So anytime he was eating, a little 3-year-old likes eating, so anytime he was eating and having a good time, she brought a caged rabbit gradually closer and closer to Peter. And Peter started to associate the rabbit with feelings of joy and being calm. And after a few months of these trials, Peter was no longer afraid of rabbits, and she took this as evidence that phobias can be induced. While phobias can be induced with classical conditioning, they can also be treated with a behavioral intervention. So phobias can be unlearned in this sense. Another really important thinker of the time was B.F. Skinner, who's associated with behaviorism. And B.F. Skinner did a lot of work with operant conditioning, starting in the 1930s and continuing on. The idea of operant conditioning was based on an observation that you could modify animal behaviors by pairing consequences with those behaviors. And the consequences were, at least in part, responsible for sort of either establishing new behaviors or maintaining desirable behaviors, as well as extinguishing undesirable behaviors. You're probably all familiar with operant conditioning from your Intro to Psychology courses, but a quick refresh. There's positive reinforcement, negative reinforcement, positive punishment, negative punishment. One really important thing to recall about operant conditioning is positive and negative don't mean good and bad. It's a little bit confusing, the terminology. Positive and negative just means whether a stimulus is applied or a consequence is applied, or the stimulus or consequence is removed. So in positive reinforcement, you want to, and then reinforcement means you want to increase the frequency of a desirable behavior, and in punishment, you want to reduce the frequency of an undesirable behavior. So positive reinforcement, for example, would be increasing the frequency of a desired behavior by applying a stimulus, and negative reinforcement would be increasing the frequency of a desired behavior by removing an unpleasant stimulus. An example of operant conditioning, say you want to increase or decrease a child's behavior. So if there's a behavior you want her to do, maybe getting along with her brother, you give her candy when she gets along with her brother, and that would be positive reinforcement. Negative reinforcement was she doesn't have to do something uncomfortable when she gets along with her brother, so she doesn't have to do chores if she gets along with her brother. Positive punishment, if the child is fighting with her brother, she gets spanked, for example. And negative punishment, she gets her toys, which is like a positive stimulus, or I'll use the word positive, an enjoyable stimulus, taken away from her if she doesn't get along with her brother. And Skinner used the principles of operant conditioning to effectively modify behaviors of some very sick, some very psychotic individuals in a hospital. This is sort of before we had better treatments for people with psychotic disorders, and a lot of times behaviors were completely unmanageable within a hospital setting. In the 1950s, there was a man named Joseph Wool who used some of these classical conditioning and operant conditioning theories and observations to create systematic desensitization, which is a therapeutic technique for treating phobias or anxiety, in which a patient pairs the use of relaxation techniques with imagining feared situations or feared stimuli in order to reduce anxiety in the face of those feared situations. So the idea is that counter conditioning is used, where you substitute relaxation for anxiety. And this is kind of the classical conditioning aspect of it. So the unconditioned stimulus would be the relaxation technique, and the response, the unconditioned response associated with the relaxation techniques is, of course, relaxation. And then in this conditioning phase, you pair the relaxation techniques, the unconditioned stimulus, with the conditioned stimulus, which is whatever causes anxiety or phobia in that person. And then the conditioned response, which is a relaxed state. So even in the face of these phobic stimuli, in the future, you would expect a relaxed state, at least relative to how the person used to be when they were in a more phobic state. There's also some operant conditioning components of this, where there's kind of extinction of behavior. So when a patient is repeatedly visualizing these anxiety-provoking situations, and there is no bad experience, so there's nothing to reinforce the fear of those situations, the anxiety responses eventually become extinguished. So for example, if you repeatedly, say you have a fear of flying, and you repeatedly fly and don't crash, then by operant conditioning processes, you sort of learn that there's no negative outcome when you fly. So in the office, what this looks like, in the clinician's office, what this looks like is getting a history of the patient's problem and assessing whether desensitization may be appropriate, and then providing the individual with the treatment rationale. Otherwise, it seems very cruel to be asking the person to imagine over and over again something that they're afraid of. And then you teach the patient relaxation training. So teach them a variety of techniques to relax. And then a anxiety hierarchy is created, where the patient is asked to sort of list from least anxiety-provoking to most anxiety-provoking situations that involve the stimulus that you're afraid of, and I'll give you an example of this in a moment. And then the therapist progressively moves up that hierarchy, starting with the thing the patient is least afraid of, moving up toward the thing that the patient is most afraid of. At each step, making sure that the patient maintains a relaxed state. The patient is to signal if anxiety increases, and then this continues until the fear or anxiety hierarchy is completed. And this can take a number of sessions. This doesn't necessarily happen in one single session. So here's an example of an anxiety hierarchy in which a patient is afraid of social situations. And the patient has listed a number of scenarios that have varying levels or increasing levels of fear, cause increasing levels of fear in them. And then they've rated in the predicted anxiety column, they've rated on a scale of 1 to 100 the degree to which this would produce anxiety. So this is a very common approach in cognitive and behavioral therapies to sort of rate different emotions and feelings and other types of things, like degree to which someone is convicted of thought, for example, on a scale of 1 to 10 or a scale of 1 to 100. And so in the hierarchy items, the patient and the therapist would move through these items together, and the patient would start making eye contact with a stranger. So they would kind of imagine themselves in the situation of making eye contact with a stranger, at the same time producing or performing relaxation techniques. And once they were able to imagine that while relaxed, they would move on to the next one, asking a stranger for directions, and the same process will be repeated until hopefully over a number of sessions they could imagine themselves giving a presentation to a small group of work colleagues, the one at the bottom, without feeling too much anxiety. So relaxation techniques that somebody might use include tensing and then releasing muscles. So this is also called progressive muscle relaxation, where you start maybe in your feet or your toes, relaxing or tensing and relaxing those muscles. And this for most people, works to physically relax the body. Breathing exercises are also super common, deep breathing exercises, and imagining a relaxing place. Exposure therapy is sort of a more updated, modified version of systematic desensitization. They're based on a lot of the same principles, but exposure therapy is a little more reliant on the operant conditioning aspect of systematic desensitization, where somebody kind of learns through facing their feared stimulus that the stimulus doesn't need to be feared. So clients are placed in anxiety-provoking situations, which can be imagined, as in systematic desensitization, or real, or in vivo. So they could be actually physically in the room with whatever is feared. Exposure must provoke anxiety. So exposure therapy is a little more challenging and uncomfortable in the sense that relaxation is not always a component of it. And somebody doesn't always necessarily start at the lowest end of their fear hierarchy. So they may start somewhere more toward the middle because they are supposed to be sort of facing their fears and experiencing anxiety at the site of this, whatever the phobic stimulus is. In exposure therapy, patients should interact with the stimulus as much as possible, keep repeating until anxiety disappears. And sessions must be of long duration, so they kind of have to live with this, feel this anxiety and be in this anxious state for a long time. And then there are more exposure sessions throughout the week. So there could be multiple sessions with the therapist, or there could be homework where the client is exposing themselves to the stimulus throughout the week. An exposure hierarchy is essentially the same thing as a fear or anxiety hierarchy. We might just be doing different things with the exposure hierarchy. So here's an exposure hierarchy for somebody who is afraid of driving, is afraid of being in a car. And so the kind of gradation is flipped on this one. So at the bottom is the least feared situation, which is pulling out of my driveway in a car. And that has an anxiety rating of about 30. And then driving in a residential neighborhood where presumably driving is a little bit easier, for 30 minutes is like a 40. And so the therapist and the client might actually do this together in real life, or if that's not feasible, for whatever situation, the client would do this, start to do these things as homework and come back and kind of report to the therapist. And if they were for some reason unable to, the therapist and the client would work together to figure out how to help the client, maybe starting even lower on the fear hierarchy if they weren't able to do anything that was on the sheet. Another common fear would be spiders. So this is an exposure hierarchy associated with the spider phobia. So again, this is flipped again. So the least feared ones are at the top, and the least feared thing would be like thinking about a spider. And then somebody might look at a photo of a spider, and then look at a real spider, but in a closed box where the spider can get on them, all the way up to letting a spider crawl on somebody's bare arm, which for somebody with a phobia would be 100 out of 100, understandably. And I have to say, exposure therapy has really good empirical evidence behind it, so it's a really effective way of dealing with phobias. I love it when somebody comes into my office with a specific phobia because it's just relatively easy to treat as long as you can convince someone to engage in these therapies. Both of these examples, the hierarchy examples, they're not from my patients, but they're people I have treated have had both of those different types of phobias, driving and also spider, and it's a really quick and rewarding process because working through the fear hierarchy really helped both of the people that I've treated with these specific phobias in terms of being able to function. So the person who was afraid of spiders was sort of just alleviated. She was living in a place that had spiders and she was just felt better about living there. And the person who had the fear of driving was now able to get her driver's license and drive people different places, drive her son to school, for example. Behavioral rehearsal is a set of techniques where a client can expand the repertoire of effective coping behaviors, and it involves a lot of role-playing and practicing behaviors both in the therapy room and outside in real life. So there are 4 basic stages. First, you explain the rationale to the client, then you create a hierarchy, sort of similar to the fear hierarchy, with the idea whether there are easier scenarios that you're going to practice first, and then the increasingly more difficult scenarios. And then you practice how you want to deal with that situation. So you practice the desired behavior within the session, and then the client transfers these skills and behaviors into real life situations, and then they will come back and you'll talk about it and see how it went and adjust as needed. An example of this is assertiveness training, where the client practices expressing how they feel, what they want, what they need. I'm doing this with a client right now who's just generally like one of those very nice people who can tend to get steamrolled in many situations, can tend to get walked on. And so he and I are just practicing in session, sort of practicing what he's going to say to different people in his life, and when he needs something or when he feels he's getting taken advantage of. And then we practice it together. So I might play his brother, for example, and then the idea is he takes it into real life and tries it, which we've had some success with. Contingency management is another set of techniques that are informed by operant conditioning. The idea is that you change behavior by manipulating consequences, and it's more common with children, adolescents, people with serious intellectual disabilities or very severe and impairing mental illness, because you do sort of have to have control over certain aspects of that person's life, and that'll make sense in a second. Some techniques within contingency management: there's behavior shaping, also known as successive approximation. And in this technique, you want to reward behaviors that are increasingly similar to the desired behavior. So if somebody's just not able to perform the desired behavior, you reward anything that's kind of close to the desired behavior, with the hope that they'll sort of gradually get toward and be able to perform the desired behavior, or be willing to perform the desired behavior. So an example of this, I'm running a group right now that's a DBT group, and we'll kind of touch on DBT later in this lecture. But in our group, we have a few clients who have difficulty controlling themselves in general, certainly emotionally controlling themselves, and like a client in particular who struggles with not talking over other people. And she really struggles, and she knows that it's something she needs to do better, and it's really hard for her to not talk over somebody else. And so anytime she starts to talk over somebody else but then catches herself, or like starts to raise her hand even if she ends up talking over somebody else, she's kind of performed a behavior that's very close to the desired behavior, and so we praise her, or just point that out and really like give her a lot of validation for the fact that she's getting closer to doing what she wants to do and what we need her to do within the group context. And the idea is, and this has been successful in past groups, so the idea is that gradually she'll be more and more able to, with the reinforcement of validation from the group members and from us as the facilitators of the group, she'll gradually be able to not talk over other people because of that reward. Timeout is another really common one. So you remove the person from the situation where the behavior is reinforced. So you might be familiar with this, especially with kids. Putting kids in timeout, kind of removing them from the attention that might reinforce negative behaviors. In contingency contracting, there's an agreement with consequences. So a lot of these are also similar to parenting techniques, or really are parenting techniques, which is why they're often used with kids, adolescents, and people who may have a care provider because of low ability to function. So agreement with consequences, for example, it's formally agreed upon that if maybe a young client hits, then he gets his Xbox taken away, and that's like the agreement, so that he knows what the consequences are going to be if that happens. The PREMAC principle, or also called like the grandma rule, is the idea that if a desired task is completed, this is reinforced by allowing the client to engage in something that's enjoyable. So it's called the grandma rule because the idea is like you do your homework first and then you get to play. And then a token economy is kind of, it's a type of contingency management, and it's often used at psychiatric hospitals where undesirable behaviors are kind of common. So people, if somebody's an inpatient in a psychiatric hospital, they're probably pretty sick, and often you get very, very sick people who have a lot of difficulty controlling their behavior at all. And there are also strict rules in an inpatient psychiatric facility for this reason, that things have to, a pretty tight ship has to be run in order for everyone to be safe and feel relatively comfortable. So token economy is common on inpatient units, and I've worked on inpatient units in the past where this is really effective, very effective. So desired behavior, which might just be like following the rules. The desired behavior might be like not breaking any rules that day, or only breaking one rule that day, is rewarded with a type of like internal currency. So they might get like sort of not actual money, but something like a voucher that will get them that they can save up and get like a candy bar or clothing, or certain privileges like going outside, like going on a walk with staff members, something like this. Another kind of extreme behavioral technique is aversion therapy, in which unpleasant consequences are associated with undesired behaviors in order to extinguish those behaviors. So the negative stimulus is applied after somebody engages in the behavior. This might be something really, really negative, like electroshock or emetic drugs, which are drugs that cause like vomiting, nausea, gastrointestinal discomfort. Another version, or like kind of less extreme version, is covert sensitization, in which somebody imagines aversive events, negative events, alongside the behavior that they want to extinguish. So if they're smoking, for example, they might purposefully imagine negative things, something that makes them really uncomfortable. And the hope is that eventually cigarette smoking would be a little bit less rewarding to them over time. The emetic drugs, just providing another example, emetic drugs have sometimes been given along with alcohol, so that alcohol has been less rewarding. So if someone has an alcohol problem, doesn't want to drink alcohol anymore, they may purposefully take these drugs that make them sick anytime they drink alcohol. Or there's also a certain drug you can take that will make alcohol make you very sick, even a small amount of it. Aversion therapy is understandably a little bit controversial. There's some ethical concerns. It is rather extreme. One important point is that research suggests that reinforcing desirable behaviors is much more effective and leads to longer lasting change than punishing undesirable behaviors. And this is kind of true across the board. Punishment is not as effective as positive reinforcement, and that goes for kids and adults, people with low cognitive functioning. This is a truism of human behavior. Some feel that aversion therapy is incompatible with human dignity. On the other hand, it can sometimes work, and it's relatively brief in duration, so it might take less time than less extreme versions. It's something that a client will willfully engage in. It's not something you do to someone against their will, so it's something that a client chooses, and it's often a last resort when other things haven't worked. One criticism of behavioral therapies has been that the therapeutic relationship is relatively downplayed, and it was definitely downplayed by early behavioral therapists. Early behavioral therapists like Skinner were all about what you can measure, and the therapeutic relationship is difficult to measure. So it wasn't historically incorporated into studies that were looking at behavioral methods and how they create change. However, we know from our previous chapters that clients often consider the therapeutic relationship to be extremely important and sometimes even paramount to improvement in therapy. More recently, behavior therapists have included therapeutic relationships and aspects of the therapeutic relationship in their studies, and behavior therapists are also being rated as warm and empathetic people. The treatment is collaborative in style, and it's kind of necessary to be supportive in order to get a person to change. You have to be, the client has to feel like they're on your side, or you're on their side, in order to trust you to engage in some of these uncomfortable things, like facing your fears, facing your phobias. So while early behaviorists may have not emphasized the therapeutic relationship as much, certainly in modern times, people who use behavior therapies still have to employ all of the basics of a good therapeutic relationship in order for these to be effective therapies. And there's research suggesting that people who do use these therapies effectively are warm and collaborative, and all the basic good things that a therapist should be. Up until now in this chapter, we've mostly talked about behavioral approaches, and in previous chapters, we've talked about some more like cognitive ways of approaching, cognitive or emotional ways of approaching the therapy. But since the 1970s, there's been a merging of cognitive and behavioral approaches, with the recognition that not all clinical conditions can be treated from a purely behavioral approach, but also a purely cognitive approach doesn't seem to be effective. And there's also been research suggesting that there's a significant impact of thinking on behavior, behavior on thinking, and then feelings in there too. So this is kind of, this little figure at the bottom is what we call like the CBT triangle, or the CBT triad. And it's the idea that thoughts influence feelings and behaviors, behaviors influence thoughts and feelings influence thoughts and behaviors. So it's like all connected, essentially. And CBT, or cognitive behavioral approaches, tend to acknowledge these relationships, or at least some of these relationships. The origins of the cognitive behavioral approach to therapy certainly started before the 1970s, before there was cognitive behavioral therapy, CBT, as a actual therapeutic modality. So one of the origins was social learning theory, which is associated with Julian Rotter from the 1950s. He found that expectations influence a person's behavior. So cognitive factors like thinking patterns or interpretations of phenomena play a role in how a person behaves. And one really important idea that that still exists today, and is still something we talk about with clients, is internal versus external locus of control. Somebody with an internal locus of control believes that they do have personal control over the events of their life, maybe not complete control, but some control over their life. Somebody with an external locus of control believes that other things control their life, and that their own behaviors don't really influence how things turn out for them in their life. And somebody, any individual person, doesn't necessarily have a fully internal or fully external locus of control. It's kind of a scale or a gradation. So an example, if there were two students who had performance anxiety over studying for tests, a therapist might encourage them to limit studying, limit the hours that they were studying. If both students did well on multiple exams with this technique, this behavioral intervention of limiting studying time, one student with internal locus of control might no longer feel anxious and stops overstudying in general. So their behavioral explanation is the consequence of doing well in the exam reinforced that behavior of limiting study time. Cognitive explanation, the student has an internal locus of control, which allowed them to connect the fact that they changed their study habits to this improved test performance. The other student might still feel anxious and continue to overstudy. So this is inconsistent with the behavioral explanation, right? They should behave like the first student if we had a purely behavioral explanation. So the cognitive explanation could give us the insight to see that a student might have an external locus of control and attribute doing well on the exams to chance and luck, and therefore fails to connect that they have changed their studying habits, and this is what's associated with the improved test performance. Another sort of origin of the CBT approach is social learning theory, which was championed by Albert Bandura in the 60s. This is probably something you heard about in Psych 101 as well. So he was famous for these Bobo doll experiments, and you can watch some original study footage at this YouTube link if you like. But essentially what happened in these Bobo doll experiments is that preschool-age children watched adults play with this Bobo doll, which was kind of like a punching bag type doll, in aggressive manners or non-aggressive manners. And the children who observed an adult acting in an aggressive way with the Bobo doll also acted aggressively toward it. The children who saw the adults interacting with the Bobo doll in a non-aggressive way were not aggressive. And this was taken to indicate that cognitive factors, so kind of like learning, social learning, can influence behavior as well. Bandura believed that people learn well and maybe learn best through modeling, which is when somebody enacts a behavior that is desired in the individual who's trying to learn that behavior, and by observing this, a person sort of learns how to engage in that behavior. So it can be used in a variety of ways. Modeling can be used in a variety of ways. For example, if somebody has a snake phobia, they can observe their therapist calmly holding a snake and handling a snake over a series of sessions. And this has been shown to help a bit with the snake phobia. The book gave another good example of videotape modeling, where females who were non-orgasmic watched a series of videotapes of another female, kind of an actress, I think, who played somebody who was non-orgasmic, learning to masturbate until reaching orgasm and then transfer these skills into orgasming during sexual intercourse. So it's something that maybe wouldn't have been as impactful if it was just a series of instructions, but because they were kind of able to observe this actress female learning these techniques, it was easier. Modeling is best and most efficient when a patient really attends to the model, retains that information, of course, that's provided with the model, performs the model behavior, and is motivated to learn or use that behavior. Rational emotive therapy was a therapy that also contributed significantly to our current CBT approaches. It was created by Albert Ellis in the 1960s, and Ellis was interested in helping clients relabel situations in their lives in a more realistic way, a way that was more adaptive. And he wanted to do this by modifying clients' internal self-talk, or this narrative that we have that colors our perceptions and our appraisals of the situations around us. He had the ABCs of rational emotive therapy, which don't actually go in order, but essentially this was the core of rational emotive therapy, is that there are beliefs that people have about these activating events or stressful events in their life that determine the emotional or behavioral consequences of those events for people. So an example might be if there's a woman, let's say there's a couple, and the woman has some pre-existing beliefs that the boyfriend doesn't find her attractive or doesn't think she looks nice on a daily basis. If the boyfriend on one day says, "Oh, you look nice today," she might, this belief may color her interpretation of that event to have her the emotional behavioral consequences of her feeling upset, because she might have interpreted that as him saying, "You look nice today," as opposed to every other day where you don't look nice. Where that is not really the most rational way to interpret that comment. Usually, "You look nice today" means simply that you look nice today. So in rational motive therapy, the therapist would work with this client to kind of help her reanalyze whether her appraisal of the situation is the most realistic appraisal. And this has certainly informed modern cognitive approaches to therapy. It's usually not used in its pure form because it's more of a technique than a modality in itself. If you'd like, there's a video of Albert Ellis conducting rational motive therapy. And then there's Meichenbaum's stress inoculation training. So his idea was that you can prevent problems and deal with kind of ongoing and future problems by inoculating clients to stressors. There are 4 stages: conceptualization, in which the client learns how thinking patterns can lead to stress or contribute to stress; skill acquisition, where a client learns skills to modify thinking behaviors and cope with stressors; and then rehearsal, where the client practices the skills in the clinic; and application, where the client uses these skills in the real world and may even further kind of encode and strengthen these skills by learning or teaching the skills to other people experiencing similar problems. Modern cognitive behavioral therapy is most affiliated with Aaron Beck in '91. So it's a newer therapy compared to a lot of the other therapies we've been discussing. It focuses on specific problems and very specific goals. It's a collaborative approach. It's empirically informed, meaning it's informed by science, by clinical science. A good therapeutic relationship is very important. It's very structured. So often at the beginning of a pure CBT session, you're setting an agenda together with the client where you decide how you're going to use the time that you have, the 45 minutes or the hour that you have together. Homework is a huge part of CBT. Homework assignments are completed between treatment sessions. So homework is something that the client's going to, maybe a skill or something that's been discussed in session that the client's going to implement outside of session. And cognitive behavioral therapy, just as it sounds, involves both behavioral interventions and cognitive interventions, and has lots of components of the techniques that we've covered in this chapter. Behavioral interventions that you might use in CBT include increasing involvement in pleasant activities to improve mood. So this is a way of changing your behaviors to change your emotions. If you want to remember back to that kind of CBT triad where emotions and thoughts and behaviors are all interlinked. So often almost invariably actually, when a very depressed client comes to my office for a first session, the first thing we do is look at what they're doing with their day. And it's often with depressed clients, unless they're somehow managing to function through their depression, often they're like staying at home, they're not going out and seeing friends. And so the first thing we do is try to kind of get them out of the house, even if it's a walk around the block. And this is associated with improvements in mood for almost everybody. Role-playing and behavioral rehearsal are very common behavioral interventions. Applying skills that are learned in the office to real world, similar to stress inoculation training. Exposure treatment, so those hierarchies, working through those hierarchies of fears. Also super common, like I mentioned before, that's what I do. Typically, anytime someone walks in with a specific phobia, which isn't that common in my setting because we work with people with more severe illness, but if someone comes in with a phobia, exposure treatment, but it also works for anxiety. So if somebody has a social anxiety, you can create a hierarchy for that. And behavioral experiments to test out beliefs. So if someone has the belief, for example, I'm a bad parent because I sometimes wish I didn't have children, they might go out and ask other parents if they ever have the thought that they don't have children. So it's kind of testing out these cognitions that are not working, but testing out like a behavioral way of testing out those cognitions. Cognitive interventions include cognitive rehearsal, where a client imagines every step necessary to complete a task so that any barriers can be identified and addressed. And this is super important because I think being realistic and kind of putting barriers, like we call it, like putting it on the table, meaning just like acknowledging that there are barriers to whatever techniques we're going to be implementing is incredibly important. Problem solving, so that means coming up with different possible solutions to a problem, pros and cons to any solutions, and then choosing the best solution. So a lot of examining the pros and cons of acting or thinking or feeling different ways in CBT. And cognitive restructuring, where we identify kind of maladaptive or automatic thoughts and challenge their accuracy, which you can kind of see the roots of rational emotive therapy in cognitive restructuring. There have been two noticeable sort of outcroppings of CBT therapy that have become modalities in their own right more recently. So one of them in the late 80s, developed by Stephen Hayes, is acceptance and commitment therapy, or ACT. And then dialectical behavioral therapy, or DBT, was developed by Marsha Linehan in 1993, or that's when she kind of started publishing her materials. In ACT, rather than working to change irrational thoughts and behaviors, the focus is more placed on an acceptance of unwanted thoughts and feelings. So the client learns to live with those unwanted thoughts and is encouraged to behave in a way that's consistent with their values, regardless of their thought in the moment. And this is, a lot of this is kind of rooted in mindfulness, which is, you've probably come across this term recently. It's, there are a lot of apps and it's kind of crept into pop culture. But in mindfulness, people are encouraged to be non-judgmentally aware of their surroundings and situations, and sort of not taking thoughts too seriously and not putting judgments on their own thoughts. DBT is primarily used with borderline personality disorder, although it's increasingly used with people in general who have any kind of emotional dysregulation. So right now I'm running a DBT group, and we only have 1 or 2 people with borderline personality disorder. More common are people with kind of like anger management problems, impulsivity issues, bipolar type presentations, even people with psychosis, and sort of some of the emotional dysregulation that comes with psychosis can benefit from DBT. And this is based on recent research as well. DBT was developed, as I mentioned, by Marsha Linehan, who herself has borderline personality disorder, and sort of used her experiences to inform the development of this treatment. And it's becoming increasingly popular. More and more people are learning these techniques and finding them to be useful with a variety of clients. It's based in 4 major skill training modules, so it's very skill-based. The first module, and what some say is the most important, is again mindfulness. So this is something that ACT and DBT share. A person is encouraged to be aware of the moment. It's a type of meditation. So you're to be aware of the moment, focus, kind of observe the surroundings in a non-judgmental way. Emotion regulation is the second module, where a client identifies and deals with emotions. So a lot of times people with borderline personality disorder or other emotion issues with emotion regulation can't even identify what emotion they're feeling. And so step 1 is figuring out what that emotion is so that you know what techniques to use to deal with it. And then distress tolerance is learning how to cope with extreme stress. So distress tolerance is developed for people who find themselves in emotional crises, and it's kind of not a long-term solution, but a short-term solutions for just weathering the storm while somebody's going through an emotional crisis. And then interpersonal effectiveness is a great module where people learn how to effectively deal with conflict also get their needs met, say no to things, to unwanted demands, for example. And if anyone is really interested in CBT and wants more information, I have a lot of materials that I'd be happy to share. I think it's really helpful for anyone, even someone without mental illness can sort of improve their own emotional life with CBT. So, reflecting on cognitive behavioral therapy, some of the strengths are that there is efficacy, there's evidence of efficacy from clinical trials for a number of different disorders. It's efficient, so it's a shorter duration than some of the other modalities. Often we do courses of CBT from anywhere from like 6 to 8 weeks to 12 weeks, and this, and sometimes patients want to stay around longer or need to be in therapy longer, but this is in contrast to like years of therapy that are often used by other modalities. It encourages a focused and well-planned treatment, so you kind of stay on track and make sure you don't get derailed by things that aren't the main focus, that shouldn't be the main focus of therapy. There's a wide breadth of application and techniques, and it's consistent with the scientist practitioner and clinical scientist models. If you remember from, I think, the very first chapter we covered, we talked about the scientist practitioner model being a clinician who is informed by, whose practice is informed by science, and clinical scientists who are informed by practice as well. Limitations of CBT. It's not particularly clear what specific aspects of treatment are always effective. Research is focused more on efficacy, so how it works in a controlled setting rather than effectiveness. It has a reputation for being kind of like arrogant or know-it-all. There's difficulties disseminating CBT, so it's not as widely used as some might expect. It's kind of widely used in my circle, but I'm trained as a CBT therapist, and so I think I am in circles where CBT is more common. And the focus on kind of ameliorating the problem at hand, or the problem that the client comes in with, may de-emphasize personal growth and a kind of like more person-centered approach. So it may not be a great fit for clients who are kind of just trying to grow as a person rather than coming in with diagnosable psychological disorders. And I can definitely speak to the limitations of cognitive behavioral therapy in a range of settings. So I work, I think I've mentioned before, in a very low resource area, high crime area of West Baltimore, and most of my clients are of African American descent and have limited educational attainment, so many of them weren't able to finish high school for various reasons. And if I take a pure CBT approach, I think it really turns off my clients. If I pull out worksheets, they're like, "What are you, my teacher?" If I ask them to do homework, sometimes they're like, "You don't understand the realities of my life," because these people are working multiple jobs and just, trying to take care of their children. So I think CBT was developed in a white, mainland, high education culture, and I don't know that it's really fully been adapted to other groups of people.